Welcome, this is Mrs. Condry, and this lecture is on heart failure from the Lewis book for NUR 1213. Our objectives is that we will describe the pathophysiological causes of acute and chronic heart failure, and we'll define the nursing process for that client. So let's go over some statistics first. Tell me, what is heart failure? Well, heart failure is an inadequate pump, and it can either be inadequately pumping or it can have enlargement, so there's less room for the blood to collect into that left ventricle. So it can be an interference with preload, afterload, the contractility, or the heart rate. So any of those factors can enlarge that heart. So congestive heart failure is an old term that you will still see sometimes, and you may still see that in some exams, although I've tried to replace it in my exams. What's replaced it now is acute and chronic heart failure, and that's replaced the term congestive heart failure. So instead of congestive heart failure, we're using the term acute decompensated heart failure, and that's when the patient is severely impacted by heart failure. Heart failure is the most common reason for older adults to get admitted to the hospital. So it's a significant problem. 10 in 1,000 people over 65 have heart failure. And the reason it's the hospitals are very aware of the problem is that now Medicare will not pay for a patient who comes in for heart failure, gets discharged, and if they come back to the hospital within 30 days, they will not pay for that second hospitalization. So there's a definitely a push to help control those chronic symptoms. It didn't say anything in the book about the mortality, but at least 50% of people who are diagnosed with heart failure won't live past 5 years. So now let's go over some cultural, ethnic, and gender differences. So African Americans have a higher incidence of heart failure with earlier onset and worse outcomes compared to whites, and that may be because there's a higher incidence of hypertension that's uncontrolled, because hypertension can lead to heart failure. And there's also more angioedema with African Americans compared to whites and Asians or other cultures from ACE inhibitors, which is a serious side effect of ACE inhibitors. ACE inhibitors are a drug that decreases our peripheral resistance, is ordered for hypertension and for heart failure. It decreases preload. So angioedema is where there's swelling through edema throughout the body into the tissues, and it can cause respiratory failure because they can actually have swelling so significantly around the throat that they can't breathe. There's another significant side effect from ACE inhibitors, and that's a cough. And that's because ACE inhibitors prevent angiotensin 1 from getting converted to angiotensin 2, but that occurs in the lungs. So Asians and women in general have a higher risk for that ACE inhibitor cough. If a patient is placed on an ACE inhibitor and they develop a cough usually within a month, that is a significant side effect, and they need to be taken off ACE inhibitors, and it's a definite allergy. Men in general have more systolic heart failure, and that's where your heart is squeezing, the heart is failing there, while women have more diastolic heart failure, and that's where the heart is relaxing. And so in a few slides I'll go over the difference between those two. And women with diabetes are more prone to heart failure than men, and that again may be, as well as with the African Americans, that women and African Americans and other cultures have less studies that have been done compared to white middle-aged men. So hypertension and coronary artery disease are the two major risk factors to develop heart failure. If the heart is having to work harder to squeeze, the ventricle can, the muscle can increase, but that doesn't help it, the heart work. It actually makes it more difficult for it to work. So that dilated heart is a side effect, and that is heart failure. So contributing risk factors are diabetes, advanced age, as we age, things happen, smoking, obesity, and hypercholesterol or hyperlipidemia. So now we can talk about left heart failure, which is the systolic and the diastolic. So you'll see that in the hospital now, the patient will be diagnosed with heart failure, and once they do an echocardiogram, they can tell if it's systolic or diastolic. So systolic or diastolic heart failure is left heart failure. Right heart failure is not. So left heart failure is classified into systolic heart failure, which the patient has a decreased ejection fraction. In the next slide, I'll talk about what that is. Diastolic heart failure is where there's that muscle's really stiff. So systolic heart failure, I think of it as old underwear. So you've lost your stretch. So the old underwear doesn't stand up well anymore, and so it doesn't squeeze around your waist like it's supposed to. So that's systolic heart failure. Diastolic heart failure is like a stiff tire. It can't relax, it can't move as well. So there's less blood filling that ventricle. So diastolic heart failure, they actually can have a normal ejection fraction because the ventricle is still squeezing the percentage of blood. It's just there's less blood filling the ventricle. So there also can be mixed diastolic and systolic heart failure, and that's where the ejection fraction is usually low. Right heart failure is usually caused by left heart failure. So usually people have symptoms of both. So ejection fraction is the amount of blood that's pumped out of that ventricle divided by the total amount of blood in the ventricle, and that's ejection fraction. So normal ejection fraction is between 50 and 75%. Below normal is 36 to 49%, and very low is 35% and below. So someone that has below 30% ejection fraction may qualify for a implanted defibrillator, and that's because if your ejection fraction is low, you are at risk for a fatal heart rhythm called ventricular tachycardia, and an internal cardioverter defibrillator will shock the heart if they go into that fatal rhythm. So our body is trying to compensate all the time. So the sympathetic nervous system, and you'll see me write it as SNS, it increases the heart rate, it increases contractility, it tries to increase cardiac output, and it causes vasoconstriction, which again will raise the peripheral resistance. So that's what it's trying to do to counteract the low cardiac output. And then there's the ROS, the neurohormonal response, which is the renin, angiotensin, aldosterone system. That's through the kidneys, and it increases sodium and water retention to increase the blood pressure. And then there's also another neurohormonal response, and that releases vasopressin, which increases our water retention. So if the cardiac output is low, all these systems are trying to increase the blood pressure, increase the contractility, increase that cardiac output. There's also endothelin, which is a potent vasoconstrictor constrictor that's released, as well as cytokines from the heart. But over time, that causes the heart to enlarge. So all these were protection for low cardiac output for a short time. But when the body's constantly under assault from this poor cardiac output, it's chronically activating these systems, and it can cause progressive ventricular remodeling. So what does that mean? It means that ventricle muscle is changing its shape. So it enlarges and it makes it less effective. So when we work out, we have big biceps. When we have big biceps, we work out, we make them bigger. That makes us stronger, and that's good. But when the heart is, the muscle is becoming bigger, it makes it less effective. So to counteract these effects, we have natriuretic peptides that are released from the atria and the ventricles, that's the heart, in response to those adverse effects from the ROS system and the sympathetic nervous system. And this increases our kidney filtration, and it helps us release the sodium, helps us vasodilate, and it decreases our blood pressure. There's also another counter-regulatory mechanism called nitric oxide, and that's released from our vascular endothelium to try and relax that arterial smooth muscle in our peripheral system. So what happens is when the body can't maintain cardiac output anymore, they have cardiac decompensation. So this is these are symptoms of right-sided heart failure and left-sided heart failure. And now lots of patients, most of them have both at the same time. But in lots of exams, including NCLEX, they will ask you to identify the symptoms based on which side of the heart could be affected. So the right-sided, think of edema in the body. It can be ascites, peripheral edema. Fatigue is really in both, even though it doesn't say it in this picture of the left-sided heart failure. Fatigue is in both. Heart failure, definitely they're exhausted. So edema can also be, you can see it in their jugular veins, and they can gain weight, and so it's edema. Left-sided heart failure can be where the edema it's more the lungs. So if they can get pulmonary edema, pleural effusions, so the fluid can be inside the lungs, which is pulmonary edema, or it can be in that lung sac, which is pleural effusions. And so they are going to get symptoms of anything related to the lungs, crackles, cough, wheezes. If they have a blood-tinged sputum, they're very, very sick. And if they're having lung issues, they're not getting enough oxygen, so they may be restless and confused. They won't be able to sleep lying down, because then the whole surface of the lungs will be covered with that fluid. So all those symptoms are related to the lungs, and then that's for the left-sided. And the right-sided heart failure is more edema throughout the rest of the body. So complications of heart failure can be pleural effusion, which I was just talking about, where fluid goes in the air sac and it can compress that lung. It can cause dysrhythmia, so it can cause a fatal rhythm, which is VTAC, and can cause AFib. And if they have AFib, which is atrial fibrillation, where the top chambers of the heart are quivering. So I'm pointing out to the lung. Let me see it. No, I don't have a picture of the heart here. Here's a picture of the heart. So if those top chambers of the heart are quivering, blood can pool, especially here, and can push clots into the lung, or it can push clots up into the brain. It can cause enlarged spleen and enlarged kidney. No, that's the spleen, and it can be liver as well, and it can cause kidney failure. So there's there's 2 different classifications in your book for how to classify heart failure, but we tend to see this one more, so I just want you to know this one is the New York Heart Association classification of heart failure. So if class 1 is mild, no real symptoms, so you can just see that yourself. Class 2 is some slight limitation of physical activity. Class 3 is moderate, and class 4 is they're not able to do any normal activities of daily living. So to diagnose someone with heart failure, they of course do a history and physical. They determine what's the underlying cause, because if it's uncontrolled hypertension, if it's heart disease, so they need to find out what causes it by doing chest x-rays, by doing labs, an EKG, echocardiogram, which is an ultrasound of the heart, and it can tell how strong or weak the heart is. They can do a nuclear stress test, or they can do a cardiac catheterization. The labs include a chemistry, and they want to check their kidney function to make sure that their kidneys are not failing. They would check cardiac markers, which are the troponins and the CK and CKMB. BNP level, that's a brain natriuretic peptide level. That is a specific test. So remember, that was a counter-regulatory mechanism from the body. We release these natriuretic peptides from the heart in response to those adverse effects. So the higher that level, the higher this BNP level, the more likely they have heart failure. They also want to check liver and thyroid function tests, because sometimes a thyroid failing, like a hypothyroidism, could cause heart failure. And they want to check lipids and, of course, coagulations and a urinalysis. So if the patient has acute decompensated heart failure, the patient's usually hospitalized. We're going to monitor their ECG. It's hard to get used to saying that term. And their oxygen saturation. They're going to monitor their vital signs and their urinary output. And if they're very, very ill, they may go to the ICU and get hooked up to for hemodynamic monitoring, and they will have an arterial line in their radial artery, and it will be measuring the pulmonary pressures and the blood pressure inside the heart. They will, of course, be applying oxygen, putting the patient up in a high Fowler's position so they can breathe. They may have aquapheresis to remove that excess salt and water from the blood, and that's like kidney dialysis, but it's just to remove that excess water and salt while they're in acute decompensated heart failure. If they're very, very sick and they have the heart is so weak, they may get a balloon pump in the ICU, and that helps to increase coronary blood flow and give the heart a little rest. And then ventricular assistive device is another thing to help the heart pump, to maintain that heart pump. So there's lots of drugs. The main drug, of course, is diuretics, because we need to get rid of that extra fluid. Vasodilators, like nitroglycerin, will be ordered to decrease the blood volume and increase that coronary artery circulation so we can get more oxygen to the heart itself. They may receive morphine, which decreases the preload and afterload and can help with that anxiety. If you can't breathe, you're very anxious, and the shortness of breath. Also positive inotropes. So those are drugs that can help our heart contract better and stronger. And there is dopamine, dobutamine, and digoxin. So dopamine and dobutamine are ordered through the IV, and digoxin can be through the IV, but it's also given orally. And then the ROS inhibitors, which are the renin, aldosterone, that system, those are given, such as ACE inhibitors and ARBs, which are alpha receptor blockers. Those will decrease the blood volume and reverse that ventricular remodeling. So these two drugs categories, which you're learning about in pharm, can reverse that ventricular remodeling, because if the heart is all boggy and enlarged, it's not going to squeeze properly. So these two drugs are important to help heal the heart a bit. It cannot reverse it completely, but it can help it. Beta blockers decrease the afterload, and it inhibits that systemic nervous system. And I already talked about the ventricular remodeling. So those drugs are very important to learn for not just a heart failure, because all of these drugs, except for the diuretics, are ordered for, it can be ordered for hypertension, and they can be ordered for coronary artery disease. So all of these drugs are used kind of interchangeably for all the different problems related to the coronary and heart system. So for chronic heart failure, we're going to treat that underlying cause, whether it's dysrhythmias, the AFib, if they have a valve enlarged, or they just have hypertension. So there's another thing that can be placed. It can be into the heart, a biventricular pacemaker. It can also be called cardiac resynchronization therapy. A biventricular pacemaker, I wish I had put a picture here. What it is there's a pacemaker that's first it's placed right under the skin, and they put wires through the vein to both ventricles. So to both ventricles. Usually pacemakers are only a single lead into one ventricle, but this helps the heart synchronize so that it's not, if it's so boggy, it's having a hard time to squeeze properly. So this biventricular pacemaker can take like 3 months, but it can help the heart heal itself, not really heal itself, but it can help it heal because it's able to give a proper squeeze. And that's usually the patient qualifies if their EF is below 30%. So remodeling results from those ventricles not beating together. So imagine if one's ventricle squeezing and then the other ventricle squeezing. That's why they have such a poor cardiac output. So that extra pacemaker lead is placed to coordinate those ventricles to beat together to increase that cardiac output. And then I already spoke about this implantable cardioverter-defibrillator that can be placed. So you can have a biventricular ICD, and that both of those things are in the same box. We call them a can. It's a battery. So it can do both the functions. It might not have a defibrillator in it, but it might. So the patient usually knows what they have implanted. So for drug therapy for chronic heart failure, it's diuretics again. They can have loop diuretics and the thiazide diuretics, and they can have the same drugs, ROS inhibitors, beta blockers, vasodilators, and positive inotropes. Digoxin is the only drug in this category that is used for chronic heart failure. But this more recent studies have shown that it doesn't actually increase their longevity, so they tend to not order digoxin as often as they used to. So nutritional therapy is very important for chronic heart failure. They should have a low sodium diet, usually 2 grams per day. And our average American diet usually ranges from 7 to 15 grams of sodium per day. So it's pretty significant decrease. So how are you supposed to do that? If you have any kind of frozen dinners, canned soups, if you go out to dinner, all those things have lots of salt. So it's really recommended that they make their own food so that you can control the amount of salt. So they may also restrict fluids for patients with moderate to severe heart failure, and that's really difficult to do. So we need to teach the patient to weigh themselves every day at the same time with the same type of clothing, whether it be underwear, nothing. It's very important so that they can have a diary to call the doctor if their weight gain is 3 pounds in 2 days or 3 to 5 pounds in 1 week. Oh, I made 2 ins there. The ATI, I noticed it said 2 pounds in 1 day. So that's also valid. It can be 2 to 3 pounds in 1 or 2 days that they need to call the doctor, because that means that the fluid is going somewhere, whether peripheral system or the lungs. So I have a mnemonic to help you remember the treatment for heart failure, and that's unload me. So the U is upright position, N is nitrates, which is the vasodilators, L is for loop diuretics, and the thiazide diuretics don't really, it's not really an L, but you get the point. O is for oxygen, A is for ACE inhibitors and ARBs, D is for digoxin, dopamine, and dobutamine, which are the positive inotropes. Positive inotropes means that it helps to increase contractility. M is for morphine, E is for extremities, up for right heart failure, just to help with the peripheral edema, but down for left heart failure so they can breathe better. And I could not think of something for beta blockers. So that's a question mark, but you still need to add beta blockers to that list. All right, so let's review. The causes of heart failure are usually from hypertension and coronary artery disease. Those are the major risk factors, but contributing diabetes are the older we get, smoking, obesity, and high cholesterol. So these really risk factors are all the same things you've already seen for hypertension and for coronary artery disease. So they all kind of, it's the same thing. They're all risk factors for any kind of heart disease. Left heart failure is classified into 2. The systolic heart failure is where the weakened heart can't squeeze. Think of it as old underwear. Diastolic is where it's very stiff, like a tire, so it doesn't have, it has less ability to hold blood in it. So diastolic heart failure, it's usually called preserved EF. So that means the EF can be normal, but it's still heart failure because they're not able to squeeze as much blood. And then right heart failure is usually caused by left heart failure. And you can look over the mechanisms that our body tries to increase our cardiac output. And then the counter-regulatory mechanisms. The reason I want you to remember the natriuretic peptides is because one of the tests that we do is looking at the level in the blood of this. In the right-sided heart failure, remember that's swelling really throughout the body, and left-sided heart failure is more of the lungs. And so if you're not breathing properly, you can get confused and restless. These complications of heart failure, it can be pleural effusion, which is the fluid in the lungs. It can cause irregular heartbeat. If you get AFib, you can get a stroke. You can get pulmonary embolism, renal failure, liver failure, all kinds of things. You can look over the New York Heart Association classification of heart failure. You can look over the diagnostic studies. And we'll be going over the care of acute decompensated heart failure in class in our case study. These are the drugs that I've talked over quite a few times. So that is it for the review. Oh, make sure you know about the weights, when to call the doctor, and that's important for teaching. So that is it for heart failure. I'll see you in class shortly.